and I'd invite her for her talk on complex cataract surgeries. Very popular pediatric cataract surgeon as well globally. Over to you, Dr. Vaishali.
Thank you so much, Maya, and thank you, Mohita ma'am, Aarti ma'am, and everybody in the AIOC Scientific Committee. I will not take too much time. So I'll be showing this case. It's not terribly complex like the cases we saw in the beginning, but this is a 16-year-old boy with an injury, and we see that there are multiple issues. The pupil is torn and ragged, and there is a white cataract, and there is a tear in the capsule. So what we do first, what I wanted to show is that always start with a small incision until you reach the stage where you need a large incision for an IOL, particularly in these young guys. Having stained the capsule with trypan blue, these are all fibrotic capsules. Most of the trauma cases, you will have some degree of fibrosis. So a combination of micro incision scissors and forceps is very useful, and therefore I like to make at least 2 side ports here and 1 here. So 3 side ports so that both hands can be used. And I'm trying to make a rhexis using a combination of cutting and pulling as much as is possible. Now here the iris is completely chafed and traumatized, so we need to be careful in coating it with a dispersive viscoelastic so that you don't make it prolapse and cause more injury. Because it's a soft cataract, you don't need phaco. Bimanual IA here works, in my hands at least, it works better than coaxial IA because I can maintain a closed chamber and I can access 360 degrees. And I'm trying to work with as low a bottle height as possible with reasonable vacuum, because we don't know what can happen in the posterior capsule. It may be ruptured, it may be intact. Plus the iris tissue, as we can see, is a little fragile. So take your time and then remove all the cortex. Every time you switch hands, as you can see here, there's a trickle of hyphema from this traumatized iris. So for maintaining the chamber and for tamponading this hyphema, I've injected a dispersive viscoelastic and I've swapped my hands. And you can see here a sort of a partial rhexis. So here there is a tear, the rest of it has been converted to a capsulotomy cum rhexis. And the lens was removed, the posterior capsule is intact. The question now would come is that as such it was the end of the case. I could have just put in a lens in the bag and the case gets over. But as we can see here now more clearly that there is no continuous rhexis. So this lens is bound to be tilted and come up and cause capture, synechia and asymmetry, which can further aggravate all the inflammation. So what I have a lot of surgeons that are both our centers we have started doing now is performing a posterior capsulorhexis in these traumatic cases where there is an anterior capsule rupture. So we electively start a rhexis under the cover of a heavy sodium hyaluronate, and again using bimanual instrumentation and micro forceps, slowly we try and make a capsulorhexis of about 4.5 millimeter diameter. With the idea of capturing, that means putting the 3-piece lens in the capsular bag, and then the optic is made to slide behind the entire posterior capsulorhexis so that it remains fixated and cannot cause any tilt or synechia. I do agree that it is not easy, and in every case I may not be able to achieve the size I want to, in which case I'll just put it in the bag. Anyway, I was going to put it in the bag. Now injecting triamcinolone acetonide, again to make sure there is no vitreous, and then filling the capsular bag. Make sure that you make space between the anterior and posterior capsulorhexis. So like I said, the safer and easier option would be just to put in a lens in the bag. But then you are endangering the eye not only with unstable IOL, but a lot of inflammation and glaucoma complications in the future. If I could not have done this PCCC, I may have left him aphakic or have done any of the sutured or non-sutured scleral fixation options. So what my first choice here is to try and put a 3-piece lens, and this animation shows why. Because you have captured the lens through the posterior rhexis, it is hopefully going to remain stable because it's a young child. Now I prefer to do a manual implantation. You could use a cartridge, and obviously the incision needs to be enlarged to 3.2 or more at this point. Anyway, the eye is going to be sutured, so I don't think the size of the incision is too much of an ego issue here. This technique only works with any kind of a 3-piece foldable IOL or even a single-piece PMMA IOL. But for that, you would obviously need a much larger incision. Now, because it's a young boy, because the pupil is so traumatized, I'm using the single pass fourth row pupilloplasty technique and trying to create some semblance of a round pupil. It's not perfect, but at least in this quadrant where there's complete loss and tattering of the iris, this would also prevent synechiae or peripheral anterior synechiae in the future. And the incision, although it's only 3.3 millimeter, has been sutured because, again, young boy trauma, we don't want any kind of instability. And this is what the child looked like post-operatively, not the ideal scenario what you wanted, but at least you have a good quiet eye and a stable IOL and a decent pupil. So I think that's